Dorothy Haynes was 71 years old and had never forgotten anything that mattered. She remembered her childhood best friend's phone number. She remembered the exact order of her deceased husband's medications. She remembered the names of her neighbor's children, her granddaughter's birthdays, the complete menu for Christmas dinner in 2019. Dorothy was the person her family called when they needed to remember anything. In March 2021, Dorothy went to the doctor because she was forgetting words mid-sentence. Common words. The word for the utensil you use to stir soup. The word for where you park your car. She would leave her room to get something and forget what it was before she got there. The doctor said it was her age. Said it was normal. Said she was doing very well for 71. Dorothy went home and took the blood pressure medication she had taken every morning for 7 years. The same medication that was doing this to her. And that no one had connected it to her complaints, because no one had asked what she was taking before saying it was her age. There are medications that enter the brain. They shouldn't, but they do. The blood-brain barrier, the most sophisticated structure that biology has built to protect neural tissue from substances circulating in the blood, is not impermeable to everything. Some molecules have specific chemical characteristics that allow them to cross it, and an entire category of antihypertensive medications, the highly lipophilic beta blockers, was built with exactly that molecular profile, small, lipophilic, capable of crossing membranes, because that profile was necessary for the desired cardiovascular effect. The side effect that no one prioritized communicating is that the same profile that allows the medication to access heart tissue also allows it to access neural tissue. And within the brain, lipid-soluble beta blockers such as propranolol, metoprolol, and to a lesser extent atenolol, block beta-ergic receptors on neurons, the same receptors that modulate the release of norepinephrine, the neurotransmitter central to memory consolidation, attention, and cognitive processing speed. In simple terms, the blood pressure-lowering drug blocks the same system in the brain that keeps memory functioning, and it does this every day, at the same dose, with the same regularity as the blood pressure is controlled. Dorothy had been taking 100 milligrams of metoprolol for 7 years, every day, with breakfast, because the cardiologist had prescribed it after a mild arrhythmia episode in 2014. What the data from the British Journal of Clinical Pharmacology published in 2020 reveals about the proportion of chronic users of lipid-soluble beta blockers who develop measurable cognitive impairment is the detail that no one communicates when signing the prescription, and that most doctors who prescribe antihypertensives do not actively monitor because the cardiology protocol does not include routine cognitive assessment. Dorothy's family noticed before the doctor did. They noticed when she called twice on the same day to tell the same story. They noticed when she didn't recognize a prescription she had written hundreds of times. She noticed when she stopped mid-sentence and stared at the wall with the specific expression of someone who had lost the thread of a thought and no longer knew where it was. Dorothy's daughter, Karen, 43, a teacher, took her mother to a neurologist in September 2021. The neurologist administered the mini mental state examination. Dorothy scored 24 out of 30 below the threshold of normality for her age and educational level. The neurologist looked at the results in Dorothy's age and began to construct the diagnosis that clinical probability supported. Mild cognitive impairment, possibly pre-Alzheimer's, semi-annual follow-up, cognitive stimulation, prepare the family for possible progression. Karen listened to everything, asked questions, took notes, and on the way out in the hallway, she asked something the neurologist hadn't asked inside the office. "Mom, do you tell me exactly everything you take every day?" Dorothy listed them. Metoprolol, 100 milligrams. Losartan, 50 milligrams. Aspirin, 81 milligrams. Aspirin, 81 milligrams. Karen photographed the list. That night she researched each one, and she found a 2021 systematic review published in the Journal of the American Geriatric Society documenting an association between chronic use of lipid-soluble beta blockers and cognitive impairment in adults over 60 years of age, with a relative risk of 1.72 for measurable cognitive impairment and 1.88 for symptoms consistent with dementia in long-term users. There were two options at that moment. The first was to continue the current protocol, Metoprolol, semi-annual neurological follow-up, preparing the family for progression. The second was to take the list of medications to the cardiologist and explicitly ask if the beta blocker could be contributing to cognitive decline, and if there was an alternative antihypertensive with less penetration into the central nervous system. The neurologist had chosen the first option without considering the second, because the second would require him to have asked about the cardiovascular medication and connected the dots between the heart medication and the brain symptoms. And that connection is not in the standard protocol for assessing cognitive impairment in the elderly. Dorothy spent another 4 months taking Metoprolol while the family prepared for Alzheimer's that might not exist. The beta blocker inside Dorothy's brain was not a surprise to the medical literature. It was a documented consequence that pharmacology had known for decades, and that the prescribing system had normalized as an acceptable risk. Beta blockers are divided into two major groups based on their ability to penetrate the central nervous system, a criterion determined by the molecule's lipophilicity. Hydrophilic beta blockers, such as atenolol and nadolol, have low CNS penetration and are associated with significantly fewer cognitive effects. Lipid-soluble beta blockers, such as propranolol and metoprolol, cross the blood-brain barrier easily and produce relevant brain concentrations after each dose. The choice between these two groups is not clinically neutral. For most cardiovascular indications, hypertension, arrhythmia prevention, stable heart failure, hydrophilic beta blockers offer comparable efficacy with a significantly more favorable cognitive effect profile. The American Heart Association and the American College of Cardiology published specific recommendations in their 2019 guidelines to consider beta blockers with lower central penetration in elderly patients or those with cognitive risk factors. In 2022, researcher Meryl Tuna and her team from Uppsala University in Sweden published an analysis in the European Heart Journal of 19,832 patients over 60 years of age who were chronically using antihypertensive drugs. The data showed that users of lipid-soluble beta blockers had a 34% higher rate of measurable cognitive decline on standardized neuropsychological tests than users of hydrophilic beta blockers controlling for blood pressure, comorbidities, and family history of dementia. 34%. With medications from the same pharmacological class, for the same indication, with equivalent cardiovascular efficacy. The difference was lipid solubility, the ability to enter the brain. A molecular characteristic that does not appear in the name of the drug, does not appear in the package insert in accessible language, and does not appear in the doctor's office conversation, because the doctor is focused on blood pressure and not on what the drug is simultaneously doing upstairs. Dorothy had been taking Metoprolol for 7 years. Over 7 years, Metoprolol had crossed the blood-brain barrier every day, twice a day, blocking beta-adrenergic receptors in the hippocampus and prefrontal cortex, the two structures most critical for memory formation and retrieval, at the same concentration with which it controlled the arrhythmia in the heart. The cardiologist who prescribed Metoprolol in 2014 had done nothing technically wrong. Metoprolol was a clinically defensible choice for Dorothy's indication, but there was an alternative with equivalent efficacy and less central penetration that could have been chosen, and no one had asked that question in 7 years of annual prescription renewals. What no American protocol for prescribing antihypertensives requires is that the physician, before choosing between lipophilic and hydrophilic beta blockers in patients over 60 years of age, ask a question. Does this patient have cognitive risk factors that make the central penetration of a beta blocker a clinically relevant variable in the choice of molecule? It's not a complex question. It doesn't require additional examination. It requires 30 seconds of anamnesis and knowledge that the difference in lipid solubility between beta blockers exists and is clinically relevant to cognitive function. The instinct to control Dorothy's arrhythmia in 2014 with the most familiar, most prescribed, most established beta blocker in American clinical practice created the mechanism that spent 7 years blocking norepinephrine in the hippocampal neurons of a woman who had never forgotten anything that mattered. The medication worked perfectly for the heart, and it did exactly what its chemistry dictated it would do in the brain. No one had asked if this was acceptable, because no one had connected the two organs in the same consultation. In January 2022, after Karen presented the systematic review to the cardiologist, Dorothy was gradually switched from Metoprolol to atenolol, a hydrophilic beta blocker with comparable cardiovascular efficacy and significantly less central penetration. The transition took 6 weeks under cardiac monitoring. 3 months after the complete switch, Dorothy underwent a new battery of neuropsychological tests. Her score on the mini mental state examination rose from 24 to 27. Her verbal processing speed improved by 23% compared to baseline. She was once again able to finish sentences without stopping midway. The neurologist documented in the medical record significant cognitive improvement after modification of the antihypertensive regimen. Hypothesis of cognitive impairment induced by a lipid-soluble beta blocker confirmed by clinical response to the molecule switch. Dorothy does not have Alzheimer's. She never had it. She had the wrong medication for the right organ in the wrong body. And she had a daughter who asked the question in the hallway that the doctor hadn't asked in the office. What American medicine has learned from Dorothy, from the data from Tuna and Uppsala, from the reviews in the Journal of the American Geriatric Society, and from the millions of elderly Americans who take lipid-soluble beta blockers without routine cognitive assessment, is that the distinction between beta blockers by lipid solubility is clinically relevant, is in the medical literature, is in the AH and ACC guidelines, and is not systematically reaching the doctor's office. What Dorothy never received was the 7 years of memory that Metoprolol was stealing every day while controlling an arrhythmia that it could have controlled equally well without crossing the blood-brain barrier. 7 years of forgotten words in the middle of sentences, 7 years of lost names, 7 years of the woman who never forgot anything becoming someone her family began preparing for Alzheimer's. The right medicine, the wrong organ. 7 years. The difference between chronic use of a beta blocker that controls blood pressure without affecting memory and chronic use that progressively compromises cognition is not the heart condition. It is not the patient's genetics, and it is not the severity of the hypertension. It is the molecule chosen, and whether anyone asked about lipid solubility before signing the prescription. If you have been taking beta blockers, propranolol, metoprolol, carvedilol, for more than 6 months and are over 60 years old, or if you have noticed any changes in memory, speed of thought, or ability to find words since you started the medication, bring this specific information to your doctor. There is a clinically documented difference between lipophilic and hydrophilic beta blockers regarding cognitive effects, and you want to know if your cardiovascular indication could be adequately treated with a molecule with less central penetration. It's not a question that questions the diagnosis. It's a question about the choice of molecule within the same pharmacological class. It's a question that Dorothy didn't know existed, that Karen found in a scientific review at 11 o'clock at night, and that changed the diagnosis from possibly pre-Alzheimer's mild cognitive impairment to a reversible adverse drug effect poorly matched to the patient's profile. One question, 30 seconds. The difference between preparing the family for Alzheimer's and changing the blood pressure medication molecule. But beta blockers aren't the only class of antihypertensives with documented effects on the central nervous system. In the next video, the diuretics that 30 million Americans take for blood pressure and that are silently altering the electrolytes the brain uses to conduct every thought, and the reason why mental confusion in the elderly is often treated as aging when a blood test would show the cause in less than 10 minutes.